Good afternoon and welcome to our first and hopefully one of many ACCC, lots of C's, Atlantic Canada Cardiovascular Conference 2020 online. I'm thrilled today to be a co-moderator together with Dr. J.F. Lagaré from the New Brunswick Heart Center, a cardiovascular surgeon. We've had in excess of 160 people register for this online webinar, and as a first effort by the ACS, I think this is really great. This, we hope, is the first of what may be a series of events to offer to you online education about cutting-edge topics relevant to cardiovascular practitioners in Atlantic Canada. Recognize this is a new format, and so it's extremely important that you, our audience, provide feedback, and we have a robust evaluation process at the end. I'm thrilled that we've had such tremendous support by our industry sponsors, and gold sponsors are Boehringer, Ingelheim, Servier, and Pfizer, Bristol Myers Squibb. Our silver sponsor is Medtronic, and our bronze sponsors are Abbott, Amgen, Bayer, and Novartis. Unique to this meeting, and something that we'd very much like to solicit your feedback on, is that we've put together a virtual town hall, a virtual exhibit hall. And there are a link that's been sent out in advance of the meeting. I would very much encourage you to access this. I've done it myself this afternoon. There's lots of information from the company website, but also the opportunity to reach out and thank, or the opportunity to meet with the various representatives of the companies who provided us with the sponsorship to carry on with the program. Our agenda is before you. There will be about 20 minutes for each presenter, and then followed by 10 minutes of audience presentation. We hope to keep this to 90 minutes, but if the questions and the comments are robust and we extend the question period slightly, we have the opportunity to go a few minutes over. The activity is accredited through Dalhousie University. You'll get 1.5 hours of credits. In order to get your credits, you have to complete the evaluation process and then go online to complete the accreditation summary. This, as I say, is our first opportunity at this online forum, and we have a number of different format of speakers presenting, some with recorded presentations, some with timed, some with live speakers. And so really, I would really highly value your feedback. Our first presenter is Dr. Lawrence Title. Lawrence is a professor of medicine and interventional cardiologist. He's been a long interest in cardiovascular trials related to atherosclerosis, and today is going to present to us his summary of the ischemia trial. Groundhog Day, here we go again, as ischemia really revisits some older clinical data suggesting about safety of medical management of patients with coronary artery disease. Lawrence.
Thank you, Simon, Planning Committee, along with Kevin, for the invite to speak this afternoon, and for offering this virtual ACCC this year in the middle of the pandemic. This afternoon, I was asked to speak about the ischemia trial, the results of which may make you think.
Groundhog Day. I'm reliving the same day. Well, it's Groundhog Day. Again?
I have no disclosures. So we all know as atherosclerosis slowly advances, eventually a patient may start to experience the symptoms of angina as a manifestation of their stable ischemic heart disease. The angina patient is typically investigated first with an exercise stress test, and not infrequently they may end up with stress imaging such as a nuclear myocardial perfusion study before they are referred to. The goals of therapy in treating patients with stable coronary artery disease are both to reduce the risk of death in ischemic events and to relieve the symptoms to improve quality of life. The management of stable ischemic heart disease patient can include optimal medical therapy, or OMT, which includes guideline-directed medical therapy, including lifestyle changes, smoking cessation, exercise and diet, control of blood pressure, lowering of LDL cholesterol, and control of blood glucose, routine use of aspirin, statins, and titration of anti-ischemic agents, including beta blockers, calcium channel blockers, and long-acting nitrates. In select patients, PCI is chosen. In some patients, coronary artery bypass surgery may be required. Let's look at a typical case. This is a 56-year-old with dyslipidemia, prior smoker, and a positive family history. He has exertional chest pain for the last 3 months. On an exercise MIBI test, he went 8 minutes on a Bruce protocol to a workload of 10.4 mets, and the MIBI showed a large size, moderately severe defect in the infralateral wall. And now he's referred to me for diagnostic cath at the start of the pandemic. Here, the right coronary artery is seen to be occluded distally. The left circumflex has a critical proximal lesion with a good distal vessel, and we see collaterals going to the distal posterolateral branch of the right coronary artery. And we see that the LAD has a critical lesion in the mid-vessel after the take of the diagonal, so our patient has severe three-vessel disease. Okay, so now what should we do, especially now in the time of COVID? Do we arrange to have stenting done to all three vessels? Do we refer the patient for a three-vessel bypass, recognizing that non-urgent surgeries are being delayed? Or do we institute optimal medical therapy to relieve symptoms through virtual cardiology clinic visits? But the real problem is that in patients like this, with stable coronary artery disease and exercise-induced ischemia, it remains uncertain whether appropriate revascularization with either PCI or CABG is superior to optimal medical therapy. And we don't know whether revascularization in this man will reduce his chance of dying or having a future heart attack compared to medical therapy. Back in 1999, I was involved in the COURAGE trial to help answer that very question. Previous smaller trials had failed to prove that PCI could improve survival or prevent MI compared to medical therapy. COURAGE was a multi-center trial in 50 sites across the US and Canada that compared optimal medical therapy alone or with the addition of PCI in patients with stable coronary artery disease to determine whether PCI could improve heart outcomes. We enrolled and managed 101 patients in Halifax as one of the top recruiting sites. The study results were published in the New England Journal of Medicine in April 2007. This slide shows the study design and the flow of the COURAGE trial. 35,539 patients were screened between 1999 and 2004, of which only 2,287 or 6% were enrolled to participate. 1,149 were randomized to the PCI group, and 1,138 were assigned to the optimal medical therapy group. They were followed for 2.5 to 7 years with a median follow-up of 4.6 years for the primary endpoint of death and non-fatal myocardial infarction. 96% of the PCI group underwent PCI after randomization with a 93% success. 32% of those in the OMT group crossed over to revascularization over the 4.6 years of follow-up. This slide shows the primary results on the hard endpoints. The rates of death and MI were virtually the same after 4.6 years in the PCI versus OMT groups. Similarly, survival, acute coronary syndromes, and the rates of myocardial infarction were the same in the two groups. However, patients treated with PCI were more likely to be free of angina at years 1 and 3, but those benefits were not sustained out to year 5. However, these negative findings were neither surprising nor new, as all previous trials before COURAGE had shown that PCI offered no benefit on mortality and myocardial. Nonetheless, there was lots of criticism of the COURAGE study. Almost 36,000 patients were screened in order to find the 2,300 study subjects, or 6%, thus affecting the general applicability of the findings. Because randomization was performed after the coronary anatomy was known from the cath, higher risk patients could have been potentially excluded, such as those with proximal LAD or severe three-vessel disease. Also, knowing the anatomy may have led to higher numbers of crossovers from the medical group to the invasive group, whereas 33% of the OMT patients crossed over to revascularization. Drug-eluting stents were used in less than 3% of CURS patients, which may have affected the long-term benefits. And finally, the study subjects did not necessarily have evidence of moderate to severe ischemia, and some studies have shown that those with more severe ischemia may have had a greater benefit of PCI. Recognizing these limitations, the ischemia trial was designed as a follow-up study to COURAGE to help answer whether an invasive approach with cardiac catheterization and revascularization could affect hard endpoints in stable ischemic heart disease. After 10 years with multiple changes in the study design and endpoints, the ischemia study was completed and presented at the American Heart Meeting in Philadelphia on November 16, 2019 by Judith Hoffman. Throughout a packed ballroom, there was eager anticipation to see. Finally, there was evidence that revascularization could improve outcomes in stable ischemic heart disease. Little did anyone know at the time that this could very well be the last face-to-face scientific session in a long time, if not forever, and how much the world would change in a matter of months. Surprisingly, the publication of ischemia was delayed for 5 months until April 9, 2020, to coincide with the American College of Cardiology conference, where additional results were to be released. Ironically, the COVID pandemic almost canceled the ACCC meeting, and the ischemia publication was largely overshadowed by the virus. However, the results of ischemia may certainly have an impact on how we treat patients with stable coronary disease, especially now. So the main question ischemia hoped to answer was that in stable patients with at least moderate ischemia on a stress test, is there a benefit of performing a cardiac catheterization and, if feasible, revascularization on top of optimal medical therapy? This slide shows the study design. Stable patients with evidence of moderate to severe ischemia on stress imaging were enrolled. The protocol was modified in 2014 to allow patients with ischemia detected on exercise testing without imaging in order to help recruitment. The majority of patients then underwent a blinded coronary CT angiogram to rule out either left main coronary disease or non-obstructive coronary disease. If the core lab found the CT angio met eligibility, the patients were then randomized to either an invasive strategy, which included optimal medical therapy plus cardiac catheterization and revascularization if feasible, or to a conservative strategy with medical therapy only and cardiac caths reserved for those who failed medical therapy. Those assigned to the invasive strategy were to have coronary angiography performed within 30 days of randomization and were to have complete revascularization by either PCI or bypass surgery. Decisions of PCI versus CABG were left to the site's heart team to decide. PCI was to be performed with FFR guidance if available and appropriate. The medical therapy and lifestyle interventions were performed according to treatment algorithms that are well described in the study design. Blinded coronary CT angiography was performed in 73% of the patients before randomization. The CT angio was done to ensure that the patients had obstructive lesions in a major epicardial vessel and to be sure to exclude those who had more than a 50% stenosis in an unprotected left main. The results were blinded to the patient and to the investigator. Those who had an eGFR below 60 or who had known coronary anatomy before the study did not have a blinded CT before randomization. This slide shows the study flow. Between 2012 and 2018, 8,518 patients were enrolled at 320 sites in 37 countries. Of these, 5,179 patients were randomized after excluding those with insufficient ischemia, non-obstructive coronary disease, or unprotected left main disease. Of these, 2,588 were randomized to the invasive strategy, and 2,591 were randomized to the conservative strategy. All patients were then followed until June 30th, 2019, for a median duration of 3.2 years. Due to slow enrollment, the sample size was reduced from 8,000 to 5,179 patients, and as a result, the primary endpoint was changed from a simple two-component endpoint of cardiovascular death and MI to a five-component endpoint that included the time to cardiovascular death, myocardial infarction, or hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. The secondary endpoints included the original two-component endpoint of cardiovascular death and MI, and a separate quality of life study that was separately published, which I will only briefly discuss today. This slide shows the baseline characteristics were similar in both groups. The average age was 64, and only 23% of the patients were female. Diabetes was present in 42%, and stress imaging was performed in 75% before randomization. This slide shows that 54% of the patients had severe ischemia on their qualifying stress test, while 33% had moderate ischemia at entry. In the patients who had a blinded coronary CT angio before randomization, almost half had three vessels affected. Left anterior descending artery disease was seen in 87% of patients, and almost half had involvement in proximal LAD. This slide shows the effectiveness of optimal medical therapy at baseline and at the end of the study. 95% of patients were on statins, 70% on ACE inhibitors or A or B. Less than 60% of patients achieved an LDL less than 1.8 millimoles per liter. 77% of patients achieved their blood pressure goals. 97% were on aspirin. 90% were not smoking. And achievement of all the treatment goals was only seen in 41% of patients at their last visit. In the invasive group, 96% underwent cardiac catheterization and 79% underwent revascularization, with 74% having a PCI and 26% having bypass. In the conservative group, 26% of the patients ended up crossing over to cardiac cath, and 21% ended up with revascularization. This slide shows the primary outcome of the five-component endpoint for the two groups of cardiovascular death, MI, hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. At a median follow-up of 3.2 years, 352 of the conservative group met the primary endpoint compared to 318 in the invasive group, although this difference was not significant with a p-value of 0.34. At 6 months, 5.3% of the invasive group met the primary endpoint compared to 3.4% of the conservative group, but this trend towards a worse outcome in the invasive group at 6 months was also not significant. As you can see, the event curves cross over around 2 years. This slide shows the secondary endpoint of cardiovascular death, or MI. At a median follow-up of 3.2 years, 314 of the conservative group met the secondary endpoint compared to 276 in the invasive group, although this difference was not significant with a p-value of 0.21. At 6 months, 4.8% of the invasive group met the secondary endpoint compared to 2.9% of the conservative group, but this 1.9% difference was also not significant. Again, the curves cross over at 2 years. The all-cause mortality was similar in both groups, with 145 deaths in the invasive group compared to 144 deaths in the conservative group. This slide shows the occurrence of myocardial infarction according to group. In the first 6 months, there was a trend towards increased myocardial infarction in the invasive group, which was related to the revascularization procedure. Later in follow-up, there was a trend towards less myocardial infarction in the invasive group, which was largely attributed to more spontaneous MIs occurring late in the conservative group. This slide shows the occurrence of the primary endpoint when a secondary definition of myocardial infarction was used that was more liberal for including a higher number of procedural myocardial infarctions. Using this secondary definition of MI accentuated the early difference between the invasive and conservative groups. And this difference persisted throughout the study in favor of the improved outcomes in the conservative group, and the curves no longer crossed over. This slide explores the heterogeneity of treatment effect according to the many subgroups. Importantly, the treatment outcomes were not significantly different in those with more severe ischemia, those with diabetes, three-vessel disease, or involvement of the proximal LAD. This slide highlights the quality of life sub-study. Seattle Angina Questionnaire scores rose in both groups, but were significantly higher in those in the invasive group out to 48 months. Those in the invasive group were also more likely to be free of angina at 4 years. In contrast to COURAGE, these improvements in angina were sustained up to 4 years. However, the greatest benefit in quality of life indicators were in those who had daily or weekly angina, and there was virtually no benefit in those who were asymptomatic at study onset. So here are the conclusions of the ischemia trial. Ischemia is the largest study of invasive versus conservative therapy in patients with stable ischemic heart disease with moderate to severe ischemia. It is the first study to randomize patients before coronary angiography was performed, thus reducing the likelihood of bias. With a median follow-up of 3.2 years, an invasive strategy did not reduce the risk of either primary or secondary endpoints compared to medical therapy alone. Patients in the invasive strategy had a trend towards more procedural myocardial infarction in the first 6 months, but as the study progressed, the curves crossed, and there was a trend towards more spontaneous MI in the conservative group in late follow-up. However, these outcomes are highly dependent upon the definition of MI used. Longer follow-up is required to determine if these differences will become significant. The ischemia investigators have applied to the NHLBI for an extension of follow-up out to 10 years. Importantly, the incidence of death from any cause was low and was similar in both groups. And finally, patients in the invasive strategy had less angina symptoms for the duration of the study and higher quality of life scores, but longer follow-up is required to look at durability. I believe the findings of the ischemia trial have a number of important implications, especially in the face of the COVID pandemic. Patients with stable ischemic heart disease that fit the profile of ischemia, who do not have unacceptable levels of angina, can safely be treated with guideline-directed medical therapy without a need to rush to cath and revascularization. During the pandemic, while we reduce the number of elective procedures, we should be reassured that we are not exposing our patients to an excessive risk of cardiovascular events or death. During the pandemic, use of coronary CT angiography may be a consideration in many patients to ensure there is no critical left main disease or severe three-vessel disease that may warrant urgent cath. So what about our patient? Well, we decided to pause after the cath, start the patient on optimal, guideline-directed medical therapy, and to only consider revascularization as the quality of life remained unacceptable with OMT. I thank you for your attention.
Well, thank you very much, Lawrence. And if you're able to turn on your webcam, great. He's appropriately masked, I see. We are a few minutes behind starting, and I apologize for that, but we have 10 minutes for questions. If you can use the question panel, we will be able to address them. I don't know, JF, if you're able to see questions. I see a snide comment about Tom Cruise, but
yeah, no, I've got John Sapp, who's got the first question here is, do we know how many of the treatment crossover occurred after the primary outcome?
As I had said in the talk, there was 26% in the conservative group who crossed over to the invasive, who went on to have a cath, 21% of which had revascularization.
But it's not, I presume it's not explained whether that crossover occurred prior to the outcome or not, I guess. That,
No.
I think John was making that distinction there.
Yeah, no. So I think some of them did not meet an endpoint prior to it, and it was probably a protocol violation, which is always a problem in these strategy trials.
Now, as you move through this, so this was obviously stable angina patients, Lawrence. How do you extrapolate some of these on not necessarily the ACS patients, but the patients who have more angina, for example, or increasing rates of angina? Can you extrapolate these findings to a much more broad population, for example? And should we be careful about extrapolating these findings more broadly?
Yeah, no, it's a good question. I mean, clearly they're going to be biased in terms of, even though this study, included much more patients who, were screened. There's still going to be people who probably have so much angina that don't even get considered. So we don't know how many of those, but it did not appear as though the level of ischemia at baseline determined outcomes or suggested any treatment benefit. And largely any benefit seemed to be driven by MIs. And as I pointed out, MIs was so dependent on the definition. And if you made the definition too liberal to include many of the procedural MIs, which don't necessarily have a negative prognostic effect, there was no effect really on mortality. So I think it really comes down to patient symptoms and quality of life.
There is another important question coming from the audience is, and you made that point, is this trial did not involve left main, but the question is, what about stable angina and left main disease?
I think we have enough evidence from the early bypass trials to suggest there really isn't a role for medical management other than in patients who are really non-surgical candidates and have so much comorbidities that the old trials, which admittedly were done before we had a lot of the newer medical therapies, but we know the survival was generally poor with medical management and left main disease.
Yeah, so another good question that I see is, many rural patients cannot travel twice, for example, and for CTA, for example, and CAD due to finances, is it safe to use optimal medical therapy alone in these patients without the reassurance that may not have left main disease or severe three vessel disease?
Now, that's a good question. I think, it's probably not unreasonable to start a trial of therapy. I think what you'll find in practice is many of these people turn out to not even have obstructive coronary disease. They're labeled as angina, have a positive stress test, and ultimately may not even have an obstructive lesion. So I think there's really, given ischemia, not a lot of harm to go ahead, treat them on spec as if they have coronary artery disease and start titrating on, usually starting with a beta blocker and then, adding other agents and including treatment of their risk factors. And only in the patients who you find that their symptoms aren't well controlled may there be a reason to bring them maybe just once for either the CT or an invasive cardiac cath if they fail that initial trial of medical treatment.
Along the same line, do you yeah, no, go ahead.
Go ahead, Jeff.
It was along the same line with the left main is, do you think that all patients still need a CT to rule out left main? So along the same lines.
Yeah, I don't know the answer. The pickup generally in many cohorts is like 5% or less patients who present with ischemia or angina for severe left main disease, but you always have that one patient you remember that surprised you, who you thought was going to have simple single vessel disease, and next thing you know, you're admitting them for urgent bypass. So there's a little concern, and I mean we're a bit spoiled that we have such easy access to CT, although I have to admit that on a few of the patients I was following in the beginning of the pandemic and I referred for CT, I got a letter back from radiology saying that they've been canceled because of the pandemic. So it kind of backfired on at least 2 or 3 patients.
Right. The comment I was going to make, Lawrence, is this is a sort of turning chronic coronary disease on its head a little bit, in the sense of they go through the process, they clinically establish the diagnosis, they do the CT scan. So you had either had imaging, a CT scan, or low EGFR to get into the study. So you've pulled out the highest risk group. And so I think, personally, my bias would be, if we're going to apply this study into our practice in patients with whom you would consider revascularization. If you're never going to consider revascularization, don't bother. Yeah. But the CT plays a role. And the other thing the CT does, and so I've used it more, as I think many people in the UK in particular have used it more, is you then establish the diagnosis. You know there's coronary disease, you know the extent, and you're not in that limbo or the surprise situation where either there's bad left main disease or there's no coronary disease, in which case you don't need all these treatments. And so I guess if we're going to do this, do we need to, across Atlantic Canada, more widely provide access to coronary CT angiograms, where my question was going? Do you think that would be an effective strategy going forward, and probably put the diagnostic cathing doc like me out of business and just leave the interventionalists and surgeons to do the work?
I think it's a great question, and I think that's really the way we should go. I would say we could probably stop doing the majority of the stress tests, and especially the stress imaging, this echo. And I think a lot of patients would be ruled out of obstructive coronary disease and would never have to see anyone in Halifax. And then the others could be, proven to have coronary disease that doesn't look life-threatening, and then be managed until you get to the point that they're not happy with quality of life.
Okay. There was another comment there about EF, and I didn't hear you raise, I may have missed it, what the enrollment EF had to be. And so the question was, does this apply if the EF is reduced, and to what level?
Yeah, I can't remember the exclusion. I think there was a low EF exclusion, but I can't remember the number.
Yeah, and as far as I know, Lawrence, they did not stratify based on ventricle function either.
No,
no.
Because many of them did not have an assessment, and all they had was the stress imaging test.
Okay.
Now, Lawrence, there is a question from, so maybe last, I'm probably extending on time there, that's asking, do you know if they've reconciled the findings of COURAGE, the subpart of COURAGE that included nuclear imaging with this? Is there an attempt to, can you draw some links here in terms of at risk myocardium, and was there a benefit or not?
Yeah, so the findings of the nuclear sub-study of COURAGE were negative as well, in that patients who had severe ischemia did not benefit in that trial from PCI. What they did show was that the PCI group was more likely to have improvement from baseline to follow-up in the myocardial perfusion study, but in fact you could not use the baseline nuclear study to predict outcome in COURAGE. So it was only a study from the Cedars-Sinai group that had previously shown that patients with moderate to severe ischemia did benefit from revascularization, and it was a single site, and I don't even think it was a random, I think it was an observational study.
I have one last comment before, JF, you can do the introduction to our next speaker. But the question here, Lawrence, is from the audience, basically says, pandemic or not, I'd come kicking or screaming to have revascularization if I had those coronary arteries. And right. So the question says, what would you do if it was a close family member or a close friend? What would you say? And say there is no pandemic. What would you say in terms of managing this patient?
Well, that's surprising, because I think it's more emotional that we got a great experience during Courage with the 100+ patients, half of which, obviously were in the conservative arm. And some of those patients I still, follow today with 3-vessel disease who never had revascularization and have done exceptionally well on medical management. I think it comes down, like, if someone is truly active and athletic, you're probably not going to be happy with quality, less likely with that kind of disease to be happy with quality of life without revascularization. I think the important thing in Courage was the lack of durability of benefit out to 5 years, and that may speak to the low use of drug-eluting stents. And it'll be interesting to see on late follow-up of ischemia how long the quality of life is sustained, because we know that disease progression and either graft failure or restenosis will change the symptom status.
Okay, Jeff, do you want to go on with the introduction to?
I do. Anyways, thank you for all the questions. There were many more questions coming out there. We tried to sort of streamline as best as we could many of them. So our next speaker is an interesting talk, obviously excellent or not, a review of the controversy surrounding the EXCEL trial results by Dr. Iqbal Bada, staff cardiologist at the QE2 Health Sciences Center in Nova Scotia. So there we go.
Thank you very much. Thank you to the organizing committee for inviting me to present. I feel truly humbled, invited to speak to our Atlantic Canada audience. So we'll get started. You read my title. I have no disclosures relevant to this topic. I have divided the learning objectives into 2 parts. I will go over the criticisms in the second half of my talk, but I want to review the actual EXCEL results to help us make decisions for appropriate patients who require revascularizations. So we will move along, and I want to review the syntax score and how it was formulated, review the EXCEL study results, go over the criticisms, and then we'll come to a conclusion. And I hope that we'll have a good discussion at the end. So the EXCEL trial used Zion stents, and EXCEL trial included left main coronary artery disease. So this is very important to understand that left main was included. And as everybody knows, there's high morbidity and mortality due to the large amount of myocardium at risk with left main coronary artery disease. And way back when, in the early 90s, when I was a trainee, when people had multivessel coronary disease, the discussions were between medical therapy versus bypass surgery. And the trials listed here, the VA study, the European study, and the CAS study were the topics of the time. And in 1994, Dr. Salim Yusuf published a meta-analysis of those studies, and I'll just like to show you some of the findings from the meta-analysis. You can see here in the medical treatment arm with the blue arrow, the left main coronary artery mortality at 5 years was 36.5%, with bypass surgery reducing mortality by relative risk of 68%. So those are drastic mortality numbers and drastic reduction with bypass surgery. Not only that, you can see here in the medically treated group, where the arrow is, the left main patients, 42% crossed over into the surgery treatment arm. So 30 years ago, we had the plain old balloon angioplasty. Stents were just starting to be introduced in practice, and now we have advanced to the current era of stenting and current PCI science. So, over the years, there have been trials comparing bypass surgery versus stents. And in this regard, I want to go over the Syntax study, which compared PCI versus bypass in severe coronary artery disease. And when you look at the initial presentation at 12 months, you see the star there at 12 months. There was increased revascularization rate with PCI, but other major outcomes were not remarkable. When the 5-year Syntax came out, there was more data to analyze and digest. So we look at the 5-year results here, and I will show you some individual graphs. You can see that the myocardial infarction rate with bypass was 3.8%. With PCI, it was 9.7%, with absolute risk reduction approaching 6%. This is a 5-year follow-up. If you look at repeat revascularization, there's a 12.2% reduction with doing bypass surgery. So what happened after then? The Syntax investigators came up with a Syntax score. In the left panel, you see detailed coronary anatomy and scoring done based on the site of the lesion. In the middle panel, you see other criteria of the coronary anatomy, including occlusion, trifurcation lesion, bifurcation, tortuosity, lesion length, calcification, etc. And that's the anatomical Syntax score as made by the Syntax investigators. On the right panel, you see the blue arrow on top, and it is a Syntax score 2, which adds age, LVEF, renal function, left main, COPD, and you can all see the other items on this score. If you use this calculator on the web, it gives you a 4-year mortality by PCI with surgery. So based on the scoring that determined that low score, low risk was under 22, intermediate risk was 23 to 32, and high risk was 33. So how did they come up with this numbers? If you see here, the low score group, 0 to 22, the only difference at the end of the 5 years is a trend towards more revascularization in the PCI group, but p-value is 0.06. If you look at the intermediate scores, there's now a difference in myocardial infarction, 3.6 versus 11% in PCI, a strong p-value, and the revascularization rate was also lower in the bypass group. So that's the intermediate score group. And if you look at the high score group, look at the death rate, bypass surgery 11.4 versus 19.2. MI is different. The composite obviously will add up to be different. Revascularization is different. So everolimus stent, or the Zion stents, was considered to be a further advancement in stents, and hence we have the Excel trial results. First published December 2016, the 3-year follow-up, and you can see that there was no controversy here at the time. You can see the composite endpoint was comparable. The myocardial infarction rate was comparable. And because of that, this data was used in the European guidelines to guide treatment for left main PCI versus bypass surgery. Now, to point out, there's controversy about this fact, which I'll come back to, and the controversy is that the Data Safety Monitoring Board had some information about higher mortality in the PCI arm, but they did not release it, which is highly unusual. But if there was a controversy. I searched the literature to see if they published anything about mortality rates. And you see here in the next slides, at about 18 months, the curves somewhat seem to be separating. So did the investigators publish anything to look at this mortality difference? And a publication in JACC in 2018, in JACC Cardiovascular Interventions, compared the mortality between men and women at the end of 3 years. And if you look at the curves here, for females, the mortality with PCI was 10.8%, with bypass surgery 6.8%. But note that the number of females in the PCI arm was around 24%, and in the bypass surgery arm was 23%. This is similar recruitment to what Dr. Title showed in the ischemia study. Females tend to be less recruited. If you look at the blue arrow, the p-value is 0.06. So the conclusion of the authors was that gender was not an independent predictor. However, women tended towards worse outcome, which they felt was related to comorbidities and increased periprocedural complications. So now we come along to the 5-year publication of the Excel study, November 2019. And you can see here, just to highlight the inclusion criteria, syntax score had to be under 32. And the last inclusion criteria is that patients had to be eligible for bypass or PCI and therefore could be randomized. So those are the important inclusion points that I want to highlight. If you look at the 5-year follow-up, 34% in the PCI group were lost to follow-up, and I've underlined the 34 there. And in the CABG group, 36 patients were lost to follow-up. Keep that in mind. When we look at the selected baseline criteria, I'll start from the bottom. 50% of patients had 2 or 3 vessel disease in addition to the left main disease. So 2 vessel, 32%, 3 vessel, 18%. You can see that left main bifurcation or trifurcation was in the 80% range. If you look at the mean age, it was 66 years. And as cardiovascular health professionals, we have to ask, are we going to manage these people so they get to the life expectancy of all other Canadians, or do we just manage them for 5 years so they don't have too much symptoms and then they can die off? We could debate this later. So if you look at the medication use, 61.6% in the PCI arm were still on dual antiplatelet therapy at 5 years, with 50% on clopidogrel, 11%, 11.6% on prasugrel or ticagrelor. Now, generally, it is not our practice to keep so many people on dual antiplatelet therapy for such a long period of time. This could be yet another item for debate. Now, when you look at studies that have closely followed bleeding, or the background here has changed, I will narrate what the findings of the ACCC study were. When they followed bleeding closely, dual antiplatelet therapy had an annual bleeding rate of 2.4% and warfarin 2.2%. But in the Excel trial, they do not give us any data on bleeding rates. So going on to the next slide, you see the outcome curves at 5 years. There seems to be a crossover at around 36 months, and you don't see the number because the background of the slide changed. But in any case, at the end of the study, there's no statistically significant difference in major outcomes. When you look at how the slides were presented by Dr. Greg Stone, he put confidence intervals there and not p-values, but there's an absolute difference of 3.1% with lower mortality with bypass surgery compared to PCI, and you see the blue arrow by 3.1%. And down at the bottom, I want to highlight non-procedural myocardial infarctions, which were 3.3% lower in the bypass surgery group. We will address the peri-procedural MIs in later slides. If you look at revascularization, lower by 6.9% in the PCI group. So here are the figures from the New England Journal, and you see the death figure that shows that the confidence interval does not cross the unity line, and yet they did not put a p-value. But on the right, I've already mentioned that there was a 3.1% lower mortality with bypass surgery. Ischemia-driven revascularization had already been mentioned before, so we'll move along and look at 10 pre-specified subgroups that the study has said we would look at. And I'm picking two subgroups here where the confidence interval lines are actually crossing the unity line. In age over 67, the confidence interval line seems to be touching the unity line, but if you look at the numbers up top, it's 1.02 to 1.89, favoring bypass surgery for patients over the age of 67. And if we look at geographic location, North Americans did better with bypass surgery. Confidence interval 1.09 to 2.26, favoring bypass surgery. The last thing I want to mention about the results is on the left side, you see the site-reported syntax scores. The investigators did their syntax scores and were able to randomize. And as you can see, the investigators say they were fully compliant with the protocol and did not randomize patients with higher than 32 syntax score, or higher than 33. When the same angiograms were reviewed by the core lab, which are the pie charts on the right, you see the red shaded regions of high syntax score above 33, so 25% for PCI. I find this is quite a lot of protocol deviation, but you could argue that 24% or 23 in the bypass surgery arm also had high syntax score. So we should just ignore it and move on. But here now we will talk about some of the controversy that broke out after the results were presented. Dr. Taggart, a surgeon at Oxford who has over 300 publications, disagreed with the publications and the release of the results and how they were done. And he raised a stink about this to the point that in the 5-year study, he withdrew his name from the authorship and has stated in several items that you can find on the internet that in 300 or so or more publications, he had never withdrawn his name. So what were his issues? He said that the universal definition of myocardial infarction was not used. The definition of myocardial infarction was changed. The mortality difference seen was not emphasized enough. The data monitoring committee had concerns, and the European guidelines based on the results were unsafe. So this whole thing created multiple coverage in the BBC. You can see here that he went on the BBC Newsnight program and said that, the results weren't valid. The other program on Newsnight talked about data being held back. And then finally, in one of the programs, the Excel leadership responded. So let's see what happened from there. Of course, social media exploded, and I've picked two samples, just two. One from Dr. Stone himself, who said Dr. Taggart is mistaken or intentionally misleading the audience. The definition of myocardial infarction was never changed. This is a delusion. And of course, there were other social media comments making their own conclusion. And you see here somebody saying one major issue not to forget, all-cause mortality was better in the bypass arm, full stop. And the p-value here was 0.002. So what happened after that? The European Association for Cardiothoracic Surgery Council met, and they put out a letter on December 19th. Their meeting was on the 7th. This letter is available on the TCT website. The council stated that it was withdrawing their support of the European guidelines for left main revascularization. Number two, they informed all their members widely that they were withdrawing their support. And number three, they asked the ESC and other bodies to review the recommendations to make changes. So when we look at their recalculation of myocardial infarction using the universal definition, they said that PCI was associated with a 40% relative risk increase compared to bypass surgery. And this hazard ratio of 1.4 truly reflected the result of higher deaths. So these MIs did have an effect. So there were other issues that the BBC mentioned, and this is to do with the Data Safety Monitoring Board having more information which they withheld when the Europeans made their guidelines. But we don't know whether this is true or not, and the DSMB has not responded. The other accusation was that there were major commercial conflicts between writers of the guidelines and some of the authors of the papers, one person having a patent for stent, and apparently the members of the guideline committees were not told about these conflicts, although the chairs of the guideline committee were aware of these conflicts. So this is an official response from the Excel leadership saying that the universal definition of MI was not suitable because after bypass surgery, surgeons put too many bandages on the chest and proper ECGs cannot be done. Chest pain assessment is problematic because after bypass, patients are sedated and they have incisional chest pain and they're intubated, and so they can never complain of chest pain, and angiography is never performed. So this was the argument given by the leaders of the Excel committee. Now, what was the definition of MI? Protocol definition for peri-operative or peri-PCI MI. So if somebody had a CKMB over 10 times normal, that's an MI. If they had CKMB 5 times normal plus new Q waves on ECG, angiogram evidence of occlusion of a graft or loss of wall motion abnormality on imaging, this was an MI. Now I can tell you that in Atlantic Canada, I'm not sure we measure CKMB anymore, so we wouldn't be able to diagnose these MIs. And so it's very interesting what their periprocedural MI rate was. There are various publications about definition of MI and the incidence of MI based on the publication, and Dr. Teichel already mentioned that in his talk. But if you look at this publication and look at various definitions of MI used, the SCI definition, which is the Society of Interventional Cardiologists, by their definition, the rate of MI here will be 18.3% with bypass, 5.5 for PCI, whereas if you look at the universal definitions, you see that the incidence of MI is much, much lower. So when we look at the periprocedural MI at 30 days, you see there is an absolute difference here of 2.3%. And if you look at the composite endpoint, this 2.3% makes up significant part of the composite endpoint and drives the entire 30-day outcome. So if you look at the bar graphs that separate the outcomes based on time. On the left side, you see the outcome at 30 days where the curves are separated. You see the middle panel from 1 month to 12 months where the curves are totally superimposed. And 12 months and beyond, you can see that the bypass surgery arm has lower event rates. So, had this bump in the early portion not happened due to periprocedural MIs where the blue arrow is, these curves would have looked different. But in any case, this is how they've published the results. The BMJ had 2 articles in the March 4th issue, and one author says publishing a paper with potential or serious or otherwise issues without addressing clinical errors questions the validity of the study. And the last part in that previous slide said that the New England Journal of Medicine had agreed to review the results of the study. These have not been released yet. So I will show you the conclusion based on the new results. And my feeling is that revascularization of left main with bypass surgery likely has more favorable long-term combined MACE outcomes and lower ischemia-driven revascularization rate, where absolute p-value is significant for mortality for MI by universal definition and reduced revascularization rate. But remember, there were 3.6% loss to follow-up in the PCI arm and 3.8% loss to follow-up in the bypass arm. So that's the criticism and the results of the criticism incorporated in that conclusion. So I thank the audience for your attention. Thank you, Simon. Thank you, JF.
So thank you very much, Iqbal. A nice summary of a very controversial area that's led to a huge controversy in terms of how we would interpret these results and the validity of the results. And so, Jeff, do you want to start moderating the questions, or do you see questions? I'm struggling a bit here with my question box.
Yeah, there's actually very few questions, other than Atta does point out that during the study protocol, which the QE2 was part of, you did measure CKMB for those patients as per protocol. So okay. It is.
No, I meant that for routine clinical practice, Jeff, we don't have CKMB.
I agree. So I do have a question, Iqbal. Do you think, think back in November, if there was not that controversy created by Dr. Taggart, do you think that we would have really thought about this a little bit more, or seen the 10-year result and then see the curve much more? Will there ever be a 10-year? Or does that put us in a position that we need to look further down?
With what we have, the controversy, JF, I think the investigators absolutely have to do a 10-year follow-up. And I just add that the Syntax 10-year follow-up was also published. And Syntax 10-year showed left main and 3-vessel disease was favored by bypass surgery doing better. So I think they would have to follow this up. Would there have been so much discussion if there was no controversy? I think if we critically look at some of the actual outcomes, you see there's a signal like mortality. And really the question is, do we just prevent mortality, or do we just prevent symptoms, keep our patients free of angina for 7, 8 years, and that's it? Or do we try and reduce mortality? So as I said, we try every patient that we look after reach normal Canadian life expectancy. So those are the questions, really.
So Iqbal, I raised this question with you earlier on today, and I think both options can be done. There is a signal that the mortality is better with surgery. Sure. Not every 80-year-old or 78-year-old or 85-year-old or every 65-year-old wants to have surgery. Is it wrong to do angioplasty in selected patients in whom their goal is to try and minimize the symptoms and longevity is not a concern? I mean, that to me is the issue that I think needs to be brought forward here is in discussing the results with your patient, what are your patient's desires and outcomes, and how do we match those desires and outcomes best with the procedures that we have available before us?
So Simon, having practiced cardiology for a couple of years, I've had patients with 3-vessel disease who've come for cath, and I've told them that if I had that anatomy, I would have bypassed surgery. But I've also told them plainly that I've reviewed their angiogram with somebody who does the stent, and they picked the stent. And people who, you know, I've asked interventionalists to talk to with 3-vessel disease, and the patients seem to be convinced that PCI is the way to go because they dread having a scar on their chest or having that 0.8% higher risk of stroke over 5 years. So I think when the interventionalists do the procedure, the results after stenting look excellent, and you've seen complex anatomy stented and look very good. But I think the long-term follow-up here tells a story. So I think, Simon, I would say we should be upfront with our patients, tell them the risks, long-term outcomes, and they can pick. So that's one part. This is a completely healthy 70-year-old who could go either way. But if there's a frail person who, you know, you see and can see they won't stand bypass surgery, you would encourage them perhaps to have PCI. So I think what your point is valid. I think it depends on the patient's comorbidities, and what the aim is, long-term or short-term.
Yeah, Iqbal, do you think then along the same lines is, again, the value of the heart team and how that can help you make those decisions?
Absolutely, absolutely, because the way patients are channeled now, they have their cath through the interventionalist or a diagnostic catheterizing physician like Simon, but they're still on the cardiology ward. They don't have the opportunity to see a surgeon unless the patient, you know, is asked, would you want to talk to a surgeon? And I have given this option, and more patients want to talk to the stenting doctor who comes and says, oh yeah, your anatomy is straightforward and we can fix you by stents, and they go for it. So
Iqbal, I'm going to challenge that a little bit because I, you know, frequently see the patients and have complex patients on the day unit, and I call the surgeon on call and say I want to have a consult here in patients that are complex, and in patients in whom, I mean, I think surgery is a good option for patients with left main disease. That's clear. There are some upfront risks. Most patients, if you presented this is the best treatment and their goal is longevity and quality of life, will take surgery. There are occasionally patients who disagree with you. You tell them they're taking an inferior choice. They can choose to do and get inferior treatment if that's what their desire is. And frequently I involve the surgeon and the interventional cardiologist in these sorts of complex cases. I think this talks about patients with sort of moderate to severe complexity of their left main disease. I don't know how many of them were simple, isolated osteo left main disease. That would be interesting to see what people would do with that. But I think we you know, it behooves us to explain to the patients what does the data show. So we've heard clearly what you think the data shows. JF, I'm interested to see what you think. Has this changed your understanding in any way in terms of how you discuss this with patients? Because there clearly are patients with bad left main disease in whom you don't actually want to operate because of their complex comorbidities. And the fact is they may not live long enough to achieve the benefit that you're going to give them with the surgical revascularization. So how do we use this, really what I'm trying to get to, how do we use this result practically, clinically, when faced with the patients before us? And so a 55-year-old with moderate complexity left main disease and other coronary disease, my read of this is that there's a survival benefit with surgery. That's what the data would show collectively. An 80-year-old with moderate complexity left main disease who's got a creatinine of 200, who's already had a stroke, who's got COPD, who's got peripheral vascular disease, like the ones we commonly see, what is your goal? And that's the question. I want to get out of hospital. I'm happy if I can live another year without pain versus I want to live to be 90. Well, they're not going to live to be 90, that person. Doesn't matter what you do. JF, I rambled there, I'm sorry, but does it change your approach? I mean, the heart team helps make these decisions in saying that you don't think surgery is going to make them live longer? I mean, it'll make their heart live longer, but the rest of them will fall apart, right? So.
Yeah, no, I completely agree with you. I don't think the Excel trial tremendously changed, our life or our practice in general, other than to state that left main stenting is viable. It can give you a great result exactly for those complicated patients that's maybe the right choice for them. And so being terrified of doing left main angioplasty is probably not the right thing. And we shouldn't be terrified of it because it can be a good outcome. But I think as long as we have discussions, we make it clear, as long as surgeons and cardiologists come to an agreement, there are clearly patients that this is the right choice for them, while the younger patient may be the one you want focus on longevity, then obviously surgery makes more sense. So it's a complementary system in my view. And I think the Excel trial does highlight that it can be safe and they don't drop dead after, and you can do well with it.
Right. I'm just trying to reconcile the questions, and Jeff, I apologize, but my questions all seem to be muddled in together. There do appear to be some related to this presentation.
Yeah, there's some that have come out now. Let me just, so currently there's let me just go through, So there is a question from Paul McDonald asking in terms of post-procedure troponins, post-PCI and cabbage. And are they captured? Are they done? And would it predict higher risk later on? So I'll ask Iqbal if he wants to comment.
So my understanding is that if the patient has PCI and they have no chest pain after the procedure, they're discharged. And most of our patients go home the same day. Some who have multi-vessel go home the next day. I don't think routine troponin is done, and Lawrence can chime in, because when these patients come for PCI, they don't come under a non-invasive cardiologist. And in terms of the surgery practice, JF, you would know whether you monitor troponins or not. So let's hear it from you guys.
Yeah, so for us, the first 24 hours, we always measure at least one level. So we'll have peak within the first 24 hours. And there's no doubt there's a troponin leak always with surgery. Just manipulating the heart, you would get some. So that's followed. And we know that in very high levels of troponin release, it is predictive of short and long-term adverse events. So clearly myocardial injury is important. So some of the questions, though, are really comments that essentially, there are probably many interventionalists in the audience, is not all left mains are left main, is one of the comments. Is clearly there's mid bodies, there's proximal, there's distal, bifurcating, and obviously all of the technical aspects of that left main are also important to consider. So those are mainly the comments, and the last comment is really that heart team is essential to all discussions. So heart team is a key here.
Agree.
I think probably it's time to move on. So Jody, if you could prep up our next speaker. We are a little bit over time, and I apologize, but the comments and feedback have been good, and I appreciate your involvement and engagement. So our final speaker today is the first two are on chronic coronary disease. This is on more what to do in the intervention with the patient in ACS, what to do with a non-culprit lesion. And Mohammed Al-Mutawa is an interventional cardiologist practicing in Memorial University in St. John's. We're pleased to have him join us. He goes by Mo, and so I'll turn things over to you, Mo. Thank you for joining.
Thank you very much, Simon. Good evening, everyone. Thank you, Simon, and Planning Committee for having me in the Atlantic Cardiovascular Conference. Thank you very much for all the hard work you guys have put in the short time during the pandemic. And thank you, Kevin, for all the hard work as well for organizing all this. My talk is going to be what to do with non-culprit lesions. I initially wanted to call the talk complete or not to complete. They're kind of sounds the same. So everyone see my screen, I guess, yeah? Just making sure. Perfect. I have no disclosure for this talk. And I'm going to basically talk about the stage PCI of non-culprit lesions in the STEMI and non-STEMI, timing of stage PCI, non-culprit lesions and what to do in a STEMI with multivessel disease and in cardiogenic shock. The background that a lot of approximately 40–60% of STEMIs have significant multivessel disease. Only 40% of non-STEMIs actually receive multivessel PCI at the index procedure, and only 10% of a STEMI receive multivessel PCI. And that's a very low number, and that's due to multiple factors, could be clinical and procedural. The, of course, extreme age, if someone is above certain age, can persuade the interventionist or the operator from proceeding further intervention, and maybe choose a pathway of medical therapy. The stability of the patient, the renal function, and of course the complexity of the lesions, contrast, duration of procedure, and of course if there are other lesion involved, such as left main or a CTO or calcific lesions. We know that incomplete revascularization has been associated with worse early and late prognosis. And finally, there are almost 8% of a STEMI present with cardiogenic shock. So there are multiple strategies how to approach the non-culprit lesions. The first strategy is to go culprit vessel only with primary PCI and optimal medical therapy for the bystander lesions, and that's been the option or the strategy for a long time. The second option was the multiple or multi-vessel PCI at the time of the primary PCI, guided by angiography if the lesion is significant, more than 70%, or by FFR if the lesion is between 50 and 69%. And the third strategy is the culprit vessel only primary PCI, followed by angio FFR-driven strategy of non-culprit lesion during index procedure or index hospitalization. And of course, it can be done after discharge as well within a certain time. There are advantages of doing everything at one-stop shop, and that could be reducing the basic complete revascularization, decrease risk of access site vascular complication, reduces hospitalization as well, and complete revascularization has been associated with improved prognosis. And of course, doing culprit only PCI have shown to reduce contrast, volume, and complication in the non-culprit lesion. PRAMI study was one of the first studies, a multi-center randomized controlled trial in the UK, where they had 5 centers with a total around 465 patients who were randomized to preventive PCI and non-preventive PCI in a STEMI patient with multivessel disease. As you can see in the Kaplan-Meier curve, there is significant change in MACE in preventive group with absolute reduction of 14%. Of course, the criticism of the study that it did not use revascularization as a primary outcome. It was unclear if similar outcomes in patient with non-STEMI, as they only enrolled STEMI patient, and it wasn't clear if the preventive PCI best occurred during emergent PCI, during the index procedure, or as a second procedure. And of course, no FFR or any intracoronary physiology was used, and whether it enhanced the outcome of this trial. The culprit trial was also a multi-center, again based in UK. Was a randomized controlled trial with a slight smaller sample. Patient, this one has a slight difference. It was randomized before the infarct-related artery PCI, but after the angio was done, and the group, the two groups were divided into complete revascularization versus infarct only or the culprit only lesion PCI, and the operator were encouraged to do it during the index or the presentation with the STEMI. However, some of the patients were done after the first presentation. And of course, it showed absolute risk reduction in MACE in patient with complete revascularization, as you can see in the Kaplan-Meier curve here. The study, the criticism of the study that there was no protocolized process, so it was hard to extrapolate whether the complete revascularization was a stage PCI, and whether the stage PCI was superior to complete revascularization in the index PCI timing. The DINAMI 3 prime multi was again a multi-center randomized around 600 patients and with STEMI and multivessel disease. This study was the first one to use intracranial physiology, and they used FFR-guided revascularization of the non-culprit lesion. And it was also, they had a specific timing for the revascularization of the non-culprit lesion was 2 days after the STEMI, where they had the culprit lesion fixed. And as you can see in the Kaplan-Meier, again, they looked at MACE, and they had absolute risk reduction of 9% between the complete revascularization and infarct-only lesion. So a second trial, this one looked at it differently. As you can tell, the DINAMI did the non-culprit lesion 2 days after, where the compare acute study looked into doing the FFR-guided PCI during the index procedure. As you can see, 83% of patients had FFR-guided PCI at the index procedure, and only 70% had the complete revascularization within 72 hours. And they again showed this kind of almost similar result of absolute risk reduction in MACE of 12.7% between the two arms. So, as you can see, both studies showed in the admission or during the first procedure, and also at 72 or 48 hours PCI that showed a similar result. This is the only large observational study I found to address the question about non-STEMI, as most of these studies looked into STEMI only. And this was an observational study of over 6,000 patients, included STEMI and non-STEMI, and they had 26 patients with non-STEMI had multivessel PCI during the index procedure, the initial presentation, and only 13% of patients with STEMI had the multivessel PCI during index procedure. And what it showed, actually very interesting results. They showed here that there is again reduction in MACE at 6 weeks and also at 1 year. But also they observed an interesting phenomenon, that there is a reduction in all-cause readmission at 6 weeks as well, with a multi-vessel PCI, versus the group had only culprit vessel PCI. Now, all these trials were well designed, excellent results, gave us at least an answers to a few of the questions. However, almost all of them were underpowered and could not answer one of the major questions is, when do we do this PCI? Is it safe to delay the PCI of the non-culprit lesion? Are we going to have the same results of MACE reduction during the index admission or as an outpatient? And that's what complete trial came to address that. And it's a multi-center Canadian led by the Hamilton group. And they enrolled over 4,000 patients who presented to the hospital with a STEMI, with multivessel disease. The patient underwent randomization within 72 hours after successful culprit lesion PCI. The non-culprit lesion were deemed angiographically significant if they were more than 70% stenosed, or if they were between 50 and 69% with FFR positive, more or less than or equal to 0.80. All patients received, of course, guideline-directed medical therapy, and the patients were followed for a median of 3 years with 2 co-primary outcomes of the composite of CV death or MI, or composite CV death, a new MI, or IDR, ischemia-driven revascularization. And the striking result, which most of the studies showed, that there is significant reduction in MACE in both co-primary result, or the outcomes they had, with reduced complete revascularization which was statistically significant in both the first co-primary and the second co-primary outcome. The limitation of the study is actually they did not evaluate the non-culprit PCI during the index procedure, as they've done it median 1 day or after the initial presentation. Although cardiogenic shock was not an exclusion criteria, no patient with cardiogenic shock were enrolled. And out of the 4,000, although a small subset, only 100 patients were with complete or chronic total occlusion were included in the study. And we know that no current RCT show revascularization benefit of CTO that reduces MACE in particular. I mean, CTO can improve quality of life, can in some sub-studies shows improvement in LV function, but that did not translate into MACE or survival. The second point that the complete trial addressed and actually managed to answer and help us understand is the timing of non-culprit PCI. If it's not done during the index admission, can it be done after discharge, and where is the timing and how far can we extend that? And when the patient were stratified into a stage PCI of non-culprit lesion with a median day 1 day during the index hospitalization, or after discharge with a median 23 days of a stage non-culprit PCI, and again followed up for 3 years. And the results were it showed comparing the culprit lesion only PCI as a strategy of non-culprit lesion PCI with the goal of complete revascularization performed early during the index hospitalization median 1 day or after discharge of 23 days. As you can see, there's confers a similar benefit on major CV event, and you can see the two Kaplan-Meier curves here. It showed that during the index hospitalization or after discharge shows a similar result, and that's actually more comforting. In fact, sometimes we tend to keep the patient extra few days just to have them to complete their revascularization, where in this trial it gives us the comfort that we can send patient home if they live in town or they close by, that they don't have to travel back again and get the non-culprit lesion addressed. And this is the second co-primary showed the same similar result. Now, what to do with the multi-vessel disease in a patient who present with STEMI and cardiogenic shock? This question was addressed in a study in 2017, which was very known to everyone as culprit shock. That was a multi-center trial. They enrolled over 700 patients with a STEMI, multi-vessel disease, and cardiogenic shock, and they looked at two outcomes: death from any cause, or the severe renal disease or failure, leading to renal replacement therapy. And the results showed that patients who received multi-vessel disease had more death and more sustained injury to the kidneys and required renal replacement therapy. And the differences were significant, with around 10% between the two arms. There is some issue with that study, and was criticized at the time that around 75 patients out of the 700 patients, which is almost above 10%, crossed over from the culprit lesion only PCI to multi-vessel PCI, and that due multiple reasons: lack of the hemodynamic improvement, discovery of a new lesion after the initial PCI, and of course plaque shift. The other criticism, they involved 24% of patients in the multi-vessel PCI arm with CTO. Again, CTO is a chronic, stable, should not be attempted in any situation except in a dedicated day of CTO, and not during and cardiogenic shock on a stable patient. So it's interesting, and that's in a way skewed some of the results. Now, to summarize the approach to someone with cardiogenic shock, what to do. I mean, there are multiple algorithms and approaches what to do with these in this situation. Again, as Dr. Iqbal Bara mentioned, that senior operators can do or fix left main better than, faster and more efficient and more accurate and better opposition of the stent than a junior operator, which is well seen and even in the surgical specialties. And of course, if the patient had a hemodynamic instability, having ongoing ischemia, uncertain culprit lesion, unstable appearance of a non-culprit lesion, if had any of these things, then you would favor go ahead and fix the other non-culprit lesion. And if the patient was stable and you think as an operator the other vessel is as direct, straightforward, doesn't require a lot of manipulation and can be done in a quick fashion. And the infarcted, the infarcted territory is small, and the non-infarcted, let's say someone comes with a small OM STEMI that needed a quick fix, but he had a large LAD, a type 3 that had a disease that need to be fixed on time at the same time, can be done at the same time. So it's all, again, depends on the operator. To summarize and conclude my talk, I'm still good with time. I'm at 17 minutes. So incomplete revascularization of non-culprit lesion in a STEMI has been associated with worse prognosis. Stage PCI of non-significant non-culprit vessel could be done during index admission or within 45 days after discharge. Intracoronary physiology assessment such as FFR, IFR is recommended in staging PCI of non-culprit lesion. And final point is multi-vessel PCI in a STEMI with cardiogenic shock is an art and science, and I would add an experience as well. Thank you very much.
Jeff, do you want to start with the questions, if that's okay?
Yeah, let me just look here. There's no questions currently from the audience, but I do have a question for Mo. In any of these trials, or perhaps your experience, just to talk about, so you have a STEMI, for example, a right STEMI, you PCI the culprit lesion, and then you look at the left-sided system and you've got, terrible high syntax, left main disease, that kind of stuff. So what's your strategy in that setting in the non-cardiogenic shock patients? So in terms of timing, approach, that kind of stuff. So obviously is balancing potentially surgery and approaching it from that point of view. Are these patients safe to go home? Are these patients from a surgical side? If you were deciding a surgery non-PCR for the left side.
Sorry, Jeff, your question is someone comes with the right-sided STEMI, but they have also left-sided disease. Is that
correct? So you PCI the right side, you've dealt with the STEMI, patient's fine, pain-free now, they go upstairs, but you happen to have left main disease and 3 vessel coronary disease on the other side, or leftover disease.
Perfect. So in this situation, patient is stable, not in shock. They would go to the ward, cool down, and then probably discuss with the surgeon, saying we fixed the infarcted area with the STEMI. It looks like we have options here. Can we? Do you think we can entertain the idea of surgery? Or we go ahead and do the PCI of left main. We've done that in our centers, and always, we looked into again the trials that shows left main stenting versus CABG in a situation where if you Nobel study basically, if you optimize the left main, you would have at least 5 years. And I always tell the surgeon, do you want to save your lima until 5 years from now? We can stent the left main, and when you come back in 5 years, we can entertain the idea of having the bypass surgery at that time. And most of the time, the patient feels like, okay, you already fixed one vessel, let's go ahead and look at the other vessel and do the PCI of left main, for example. Unless it's involved, of course, trifurcation, it's not as simple, straightforward. It's as Simon mentioned, if it's osteo left main, is it straightforward? The technical procedure is not going to put the patient at harm. And of course, we look at the longevity of the stent. Is it going to last long or not? Again, with the newer stent designs, when optimize and use intracoronary imaging, it can preserve the stents for a longer time. Most of the trials in the past showing the left main didn't last long. The left main PCI was related to not utilizing imaging, undersizing of left main, using old stent, using bare metal stent, not putting patient optimal medical therapy. All these factors have changed the modern intervention, but at the end of the day, it's a heart team approach to address these lesions. I had a situation just a week ago when the patient presented with anterior STEMI and was crashing on the table. When I did the angiogram, I found he has proximal mid-LAD, severe critical disease, but also he had left main disease. The patient would not last or would not be able to reach the OR, and we had to immediately fix the LAD all the way back to left main. Would the patient come back in a few years for maybe another surgery? I think, stenting left main LAD would preserve the distal or the mid LAD for future graft sites.
No, if you were going to read the question, so this is a question coming from the audience, a little bit similar to this, but from Greg Hirsch in Halifax. So once culprit PCI carried out, and there is a potential for prognostic advantage to surgical approach, for the remaining lesions, do patients get to express that preference? And
Absolutely.
How do you approach it in your? Yeah.
Absolutely, and that's when the patient, after if the patient is stable, again, we're not talking about cardiogenic shock. If the patient is stable, they go up in the unit, and you would basically, usually the intervention is different than the cardiologist in the unit. And if of course, if the interventionist, if let's say it was I'm the interventionist and at the same time the cardiologist up in the unit or in the CCU, the approach is, of course, I can do the simple math of calculating the syntax score, looking at the complexity of the lesion, and then, of course, involving a surgeon. And then we can take this further to the CB round, the heart team approach, and say, this is the patient, he's stable now, he has trifurcation of left main, and we come up with the best option for the patient, which is probably CABG over PCI, and then we go to the patient, given that STS score is within reasonable range, and also look into the longevity, the best result for the future for the patients in terms of revascularization. And we present that to the patient in terms like, CABG is better for you in this situation, and we should go with that. But if it was single, straightforward, let's say osteo-LAD or left main that can be done without compromising other vessels or creating any complication, then we would go ahead with PCI.
Jody, can you turn the other presenters on and just ask them to turn on their microphones? So, Mo, I'm going to come back to a little bit about what you said. So I don't think there's anyone that would argue that primary angioplasty has been an advance in the care of our patients. And there are very few patients in whom the surgeons want to take someone who's actively having an infarct and wait a few hours to get them to the OR because they're inflammatory. But one of the things that primary PCI has changed is if you got successful thrombolysis, and 70% of the time it works, and you then had a cath and you had surgical disease, you had surgery. And now what happens is you've got surgical disease, but you're acutely unwell, and we fix something. And I know, Lawrence, I've seen this, I've talked to the interventionists, they look at all the coronaries in our lab first before you fix the culprit. Like, that's too many people have been burned. But we primary PCI has converted a subgroup of patients who would have been surgical had they got successful thrombolysis to patients who get intervention. They get an intervention acutely, and now you're in the quagmire of you got an acute stent, you've got dual antiplatelet therapy on board for an undetermined period of time. And treating patients with acute coronary disease and the outcomes with acute coronary disease is very, very, very different than the chronic coronary disease we were talking about. The event rates, the recurrent event rates, the death rate in the short term, the need to do something is higher in an acute patient. And so I guess coming back to JF's question, I'm going to repose the question. Does anyone ever do an angiogram, see a culprit vessel, do a plain old balloon angioplasty, get the vessel open, and call the surgeon? Because I think you're getting to the point where you say the surgery is better for complex left main disease, but you fix the right and you've got residual complex left main disease. Like, how do we reconcile that? I've never talked about that or heard people talk about it at a conference, but it does change the management. And surgeons, I've been there, surgeons have been called and no, I don't want to operate, go ahead and fix it, we'll deal with it afterwards. Which I think acutely is what happens. But Lawrence, do you know
well,
others?
we've had this discussion in relation to patients before, and you know, I think you have a good point that sometimes people just charge ahead. I know some of my colleagues don't even look at the contralateral vessel and go right in with a guide. If it's an inferior, they go in with a JR4 or whatever guide they're going to use and fix the right. Don't even look at the left. Which to me is not the right approach. You know, most of these patients aren't that unstable, and the time it takes to look at the full anatomy and the left ventricular angiogram, I think it's a better decision in terms of what the ultimate treatment is. Most surgeons, I find, will not take these patients directly from the cath lab to the OR unless they're in cardiogenic shock and, you know, going to die otherwise. You know, they're spooked by the clopidogrel loading dose or ticagrelor. And so usually, you know, you're tempted to do something to reduce infarct size. And I think your point about just doing a balloon angioplasty, especially if you have identified severe left main disease that's not ideal for PCI, it's a complex bifurcation lesion, plus there's disease beyond the left main in the circ or LED, that we should, you know, just maybe open the RCA, get some flow, get the patient stabilized, put a balloon pump in if necessary, and then, you know, let the surgeon wait their 48 hours or whatever to have the clopidogrel wear off. But I think charging ahead isn't necessarily the best thing for the patient in the long run.
Okay.
There is one question, Simon, from the audience, if you want to.
Please,
so
Jeff.
It's a question on time. It's a question on timing from Sharif. You know, it is one of those things that, let's say you do fix one vessel and the patient then is referred for surgery and the patient goes home. What is the optimal timing? I know Sharif is concerned in the question, you know, do you wait the 3 months for the antiplatelet? I certainly know that our practice here is that we use Integralin quite a bit, so we don't worry about the dual antiplatelet. They come back in, we start Integralin, we can do it at any point in time. But based on the studies, what is the safe window that you would have for delaying the revascularization?
With the science, it's what's recommended in the guideline, and the Canadian guideline is that it's 3 to 6 months before you'll be able to stop the Plavix. My experience when trained in Europe, they actually can accept with Xience with 4 weeks Plavix, and you can stop it and be on aspirin only. I've used Xience. There's another stent that is made by Boston Scientific called Synergy Stent, and there's the other stent, again, it's not available in Canada, and the third one is Osario. And the 2 stents being proven and evidence showed in multiple studies that you can stop the Plavix after 4 weeks, and there's early endothelialization of the stent and safe to stop the Plavix. Again, question to you, Jeff. JF is I've seen surgeons operating on Plavix without, you know, concerns, like almost a week later or a few days later, and they operate. And it's again, I don't know, some surgeons feel very comfortable doing it, some surgeon feels uncomfortable doing this procedure. To me, as interventional cardiologist, I just find it's a preference. I'm sure there are studies and evidence, but I've seen different surgeons approach it differently. So
yeah, there's no doubt there's practice variation, but the reality is you're going to accept the higher risk of bleeding and the morbidity of a transfusion reaction, a transfusion you'll provide. So it's accepting that risk. But for the antiplatelet question is not that hard in my mind. If you have somebody you need to have on clopidogrel and you can bridge with Integralin, then you really never have a period of time of which you're off the clopidogrel for any period of time other than the day of the surgery. During the procedure, they're going to get the Plavix within the first 12 or 24 hours after their procedure. So they're really essentially never off. So my question was really about the timing. Is it safe to wait a month for doing the completion revascularization? Is it, or should that be done sooner? Is it safe to wait? What is safe?
It is safe to wait up to 45 days according to complete trial. If you do index stenting of the infarction-related artery, according to the complete trial, you cannot wait up till 45 weeks before you do anything. So 6 weeks, that's your wait time, which is a great timing. Now, I've seen people going even longer, but I think 6 weeks is a great timing for the Plavix to be discontinued and can be patient can be brought back.
So the other question to Mo and Lawrence and perhaps JF, if you can speak for St. John, is how widely adopted has the complete trial been? And, we've got this paradox that we've got patients with chronic stable disease that we're showing that we can successfully treat medically. Very complex disease, needs surgery. But when you have an acute presentation, we seem to need to do things fairly quickly. And this topic was brought forward by our content committee, who I want to thank because I forgotten to, but the comment was people are coming back and some of them have everything fixed and some of them have nothing else fixed. And I can't figure out why you guys are doing what you're doing. So what are you doing? And so perhaps, Lawrence, you could say what we're doing as a center, primarily with patients with residual disease. Is there a single approach? Is it a nuanced approach? I think Mo talked to some of the features at the beginning.
Well, we were involved in Complete, and I would say that after the results were released, and this is before going into the pandemic, that there was pretty well universal acceptance of the results. And for the most part, I think lesions more than 75% in a major epicardial vessel were being recommended to be staged, usually staged. Some operators were doing them in the same sitting. And it was those borderline ones, especially branch disease, that maybe left for medical management. I think what we maybe saw was a little change, during COVID, where maybe some of the more borderline lesions, some of us might have said, that could be left for medical management, or if the patient has recurrent angina, we can do it down the road.
Mo?
So multiple approach, multiple different ways. It depends on the patient's stability and complexity of the lesion. If I go ahead and fix the, let's say, LAD, and the patient's stable, rock solid, no issues, then I'll probably fix the circ, which is critical, same time, and then get out. If the patient is unstable, I had to fix the LAD, then they stabilize this with the LAD fixing, I'll get out, and I will bring him back in a day or two.
So Mo, I'm going to rephrase the question. So the patient is stable, they've got residual disease. Do you fix them in hospital? Do you bring them all back? Or do you say still some of them should be medically managed? Like, that's really what people were asking.
So we're fixing everything in Newfoundland. Okay. Most of, I would say 99% being fixed inpatient. Most of the patients in Newfoundland probably have the same thing.
I think to help answer that, if you look at the results so far, and maybe it'll change with late follow-up, but the main thing driving the outcome is preventing MIs. We're not preventing changing survival. So I think you have to wonder what's the consequence if you left that lesion, untreated. Would an MI be sizable, prognostically, important? That I think use that to help guide. There was a sub-study, we weren't participating in an OCT sub-study, but what was interesting was a large percentage of the non-culprit vessels were thin cap fibroatheromas that potentially are more vulnerable to plaque rupture. And we know that in the first 6 months with an inflammation that there is an increased risk of recurrent events, and it may be these TICFAs that are potentially unstable in a pro-inflammatory environment. There'll be, I'm sure, a lot of sub-studies that have complete looking at what was driving the infarct.
JF, do you know what the practice is routinely in your center?
I mean, I wish I could tell you the ones I get called about this because there's residual surgical disease,
right? And
they fixed the one vessel. And my practice personally is, if it's a very large infarct, I do like a little bit of time to let those patients recover because they benefit from that recovery. Otherwise, we tend to fix them in that hospitalization is our strategy.
Okay, thank you. So I'm just looking, I can see the number of attendees. So we've lost 15 by going 25 minutes over. I apologize for the delay. I did take a little longer at the introduction. We hadn't built that in. The comments and questions have been great. JF, I can't see the new ones, the most recent. Is there anything else there before we close?
I'll give the last question or comment from Paul McDonald. So more colchicine and ticagrelor. There you go.
For another day, Dr. McDonald. We'll address that. Just a couple of other comments before we close. So once again, I'd like to thank everyone for their participation, in particular our speakers, Iqbal, Lawrence, Mo, great job on topic to what had been requested. The feedback and the questioning the questions from the audience has been great. I think we have a slide once more to show, Jody. I just wanted to re-thank our presenters. Support from our corporate sponsors here who've been involved in education grants. They haven't chosen the topics. We had 21 topics for the full meeting. We hived it down to 3 to sort of thematically link them. But Boehringer Ingelheim, Servier, and Pfizer, Bristol Myers Squibb for our gold sponsors. Medtronic is silver. Abbott, Amgen, Bayer, and Novartis as our bronze sponsors. So thank you. So so comments about the format, comments about the method that we use, the medium that we've had. I would like to thank Jody McComb from the CCS, who's helped us with the technology, and Kevin McKenzie, who's done a huge amount of work behind the scenes, in addition to the content committee who put forward the topics. We are exactly 27 minutes over now. I think this closes at 5:30. So with that, I'd like to thank you all for participating. Enjoy the weekend, stay safe. And if you like it, we'd like to try and do it again, maybe a couple of times through the year. So let us know that. Thanks very much.